Thank the ranking member. Thank the chair for having this hearing as well. Mrs. Miller, thank you all, and thank the whole panel for being here today. Ms. Miller, your testimony mentions the period between lab research to clinical trial launch as the valley of death, taking anywhere from 10 to 15 years and billions of dollars, as I understand it, before a new antibiotic can come to market. So how can we build on successful public-private partnerships like CarbX to bring more clinical antibiotic candidates to the market?
So as I mentioned before, CarbX has been really great at reinvigorating the pipeline. Unfortunately, some of those products are, far from actually coming to market. But BARDA has other programs, other private-public partnerships that are helping to bring innovation to the marketplace faster than if companies were trying to do that on their own. We just announced a recent partnership with BARDA for a private-public partnership, and what that will allow us to do is bring innovation for pediatric patients to market faster.
Thank you for that. When I go on their website for CarbX, it shows a little over $300 million, a little under $400 million that has been invested. Yeah. What attracted those dollars, and how do we make that more if it's a good program?
Well, I think the first thing is focusing on where is there an unmet medical need, right? So we see the trends, we see where infections are higher, where resistance is higher, and so when companies can bring forward ideas to CarbX for funding, there's an opportunity there for collaboration. There's also the need to focus on preparedness, right? So not just the infections that we're battling today, but what could be the infections in the future, the pathogens that we need to be most concerned about from a biothreat perspective. There's opportunities to collaborate there as well.
Thank you. Now, you also mentioned a second valley of death when the FDA approves a new drug, but patients can't access it because hospitals keep physicians from prescribing the newest therapies. Mm-hmm. So can you go into more detail about the perverse incentives that are out there that keep new therapies on the shelf instead of being prescribed to patients? And then what reforms to the GAIN Act should Congress pursue to bring more novel drugs forward and to ensure patients have access to those drugs?
Well, I want to make sure that it's clear that we support antimicrobial stewardship. We believe it's important to use the right drug at the right time for the right bug. And so stewardship is important, and as a result, antibiotics and antifungals are going to be used more sparingly than you would see a typical product, especially in a hospital setting. However, the way reimbursement is set up in the hospital with DRG, hospitals are incentivized to use cheaper or less expensive medication than newer, more potentially costly innovation. And so what we'd like to see is a reform to reimbursement so that hospitals are not incentivized to put our newer antibiotics on the shelf in reserve, but to use them when it's appropriate. They need to do the right testing, of course, but when they see that a bug is susceptible to a newer antibiotic or to a newer antifungal, they shouldn't be prohibited from using that because of cost. At the end of the day, the cost of inaction, of not using the right product sooner, costs the healthcare system money, and of course, it costs lives.
Thank you for that. Again, thank you all. I yield.